Hi everybody, I'm Katie Roberts. I'm the Primary Care Liaison Manager for Cambridge University Hospitals. I think we'll just give it another minute just to see if anybody else is joining, and then I will introduce you to Katie Leonard, who will then introduce our panel. There's no one else waiting to come in. So did you want to start, Katie?
Absolutely. Welcome everybody. And firstly, thank you for joining us today to discuss the CUH Teledermatology pathway. My name is Katie Leonard and I'm the Deputy Operations Manager for Dermatology here at Addenbrooke's Hospital. I'm joined on the call by some colleagues that work at the CDC. So welcome to Hilary Charlesworth, Gareth White and Bruce as well. And then from CUH Dermatology, we have Dr. Andre Koo, Consultant Dermatologist, and Ella Bavalia, who is the Lead Medical Photographer for Teledermatology at Addenbrooke's. So welcome to everybody here. So we are recording this session, just to let you know that the session is now recording. If you have any questions, you can use the chat function. We will give you an opportunity at the end of the webinar to answer any questions that you may have. So we're going to share the slides if that's okay, Katie. Okay, so today we're going to talk a little bit about the teledermatology pathway and explain how that works in a bit more detail. You'll have the opportunity to ask any questions towards the end of the session. The second part of the session will include some teaching led by Dr. Koo. Just to notify you also that we are holding a separate day dermoscopy course here at CUH. I believe it's on the 3rd of June, but I'll send around the information afterwards. If anybody would be interested, there will be an opportunity for some spaces for the local GPs to attend for a small fee. Please do notify me. I'll let you know of the information after the call. So there are many different forms of teledermatology across the country, driven by a significant increase in cancer demand and the need to respond to that demand in an innovative way without additional resources. So the teledermatology model that CUH follows is the pathway on the next slide, if you could. So the GP will identify a lesion of concern. The new skin lesion form referral form will guide you on what is accepted through Telederm, and the GP to highlight the exclusion criteria where that patient is not suitable. Ella will go into more detail about this in her part of the session. Then the option to refer to teledermatology through ERS if they are suitable, or you can refer through face-to-face if the patient is unsuitable. Please do use the exclusion criteria if the patient is unsuitable, so we know not to put them through teledermatology. The patient will then attend a face-to-face appointment at one of the chosen sites. So all of those sites are available on ERS. We now operate out of EDCDC, Huntingdon Road Surgery, Sawston Medical Practice, and at the Cambridge Dialysis Centre, and all of those options are available to everyone. The medical photographer will then take photos of the lesion as highlighted on the referral form, and they will upload the images that they take to Epic. Again, Ella will show you in more detail about the types of photos that she takes and the dermoscopy imaging. Following this, the patient will be booked for a virtual review appointment with the clinician, who will then decide on next steps. As you can see from this slide, the sort of general outcomes are we could either see them for a face-to-face appointment if we want to see them for a full skin check. We will discharge them from that appointment if we think we don't need to see them. We can list them directly for a procedure, so either a biopsy or an excision or another type of treatment, or we can refer them on to plastics for a face-to-face if we believe that they would be better treated with plastics. So why teledermatology over face-to-face? Next slide, please. So the main benefits, obviously there are a number on here, but the main benefits to us are the improved access to care and the convenience. So some of our work that I'll show you on the next slide shows the patient experience surveys that we've done recently, and most of those patients have been happy that they don't have to come to site. So obviously parking here is a nightmare. Patients much prefer to be seen in their local community. So we've tried to address all areas of it within sort of the Cambridgeshire patch so that patients can get to a clinic, an accessible clinic with free parking. And then that in turn avoids multiple visits to CUH as well. So sometimes those patients don't need to come on site until they have their test done, which is great. Reduced waiting time. So since the launch of the Teledermatology Direct Access Pathway, which was in November last year, we've managed to sustain seeing cancer patients within 2 weeks, which is a massive improvement for our service. So obviously it's best care for your patients and for us as a service. And then also for efficient triage and diagnosis. So not only does this support patients that are suspected skin cancer, but actually we can see your basal cell carcinomas earlier as well. And if there's any risk to the patients that you want to put on urgent, not sure whether to put them on urgent or suspected skin cancer, if you send them through Telederm and we have any suspicion, we can upgrade them and much quicker. So currently the wait for a first appointment in dermatology for routine appointments is a year. So this obviously accelerates the lesion pathway for those patients, which is best practice for us, given the waiting list size. So next slide, please. So this just shows the revisions made to our new skin cancer referral form that we went live with in November as part of the direct access referral service. So just it highlights on here about the suitability for those Telederm patients. If anyone has any questions, related to the exclusion criteria, then we'll give you an email address at the end that you can contact if there's any queries you have, or if you'd like to ask anything further. Ella again will go into a little bit more detail about some of the exclusions and why we have those there. So I'm going to hand over now. It might be one more slide, actually, patient feedback. Sorry, one more slide, please. So patient feedback is really important to getting this service right and to support our expansion of the service. So here shows our feedback that we've had from an experience survey last June. The main feedback we had was around patient information for Telederm. So we have now launched a new website dedicated to Telederm at Adam Brooks, and also a patient information video as well, so they can see what will happen at their appointment, after their appointment, and any follow-up that would be required after that. And then the next one just shows a bit of feedback specifically about Ely. So just one more slide. And then if anyone, obviously we'll share these around afterwards, so you've got a bit more detail. The thing I noticed about the Ely, obviously some people had written that the appointment wasn't convenient for Telederm, but at this point we were offering it to people around the Cambridgeshire area because we didn't have many other locations open. So we do need to do a new experience survey on that. So next slide, just to recap. So the benefits of the direct access, so obviously your patients are seen and assessed more quickly than a face-to-face pathway. We can see more patients through the Telederm pathway as well, which obviously means we can see them quicker. The aim for a photography appointment is by day 7 and the consultant review by day 9 following that referral. Patients can select their medical photography appointment similar to the current face-to-face, and they can have that at a site that it's convenient to them and then avoids cancellations and delays. Medical photographers also can raise concerns, and reviews can be brought forward if they feel that it is necessary. Medical photographer quality is far superior to alternative Telederm models, and it enables superior accuracy of consultant review and diagnosis. And obviously, it's great that we've had positive patient feedback, and we'll keep doing some patient experience surveys on that. The slide below this information below just shows about our outcomes. So our discharge rate is somewhere between 40 and 50% at the moment for patients that are seen through Telederm. So that means 40 to 50% of patients never need to come on site for their review, which is great news. I'm going to hand over to Ella now, who's going to talk to you a little bit about what happens at the appointment.
Hello, yeah, I'm Ella. So once patients have been decided on part of the pathway and booked into their Telederm appointment, that's when us photographers then start our work. And so what we start by doing before the clinics, we will start by checking the referrals. and see if they're suitable for telederm. So going back to that exclusion criteria, we just check all of that, and if they're not suitable, we then have to organise for them to be rebooked. So that can take a reasonable amount of time. So that's why it's so important to try and familiarise yourselves with the exclusion criteria so that patients are booked in correctly. But before, so when on the day of clinic, before we call patients through, we again will check through the referral and the pre-appointment questionnaire, which we hand out to patients to complete. And then we check all of that, make sure that patients' expectations, we have an idea of what patients' expectations are, and that it correlates to the referral. And then we confirm with the patient what is going to happen and what happens next, and we confirm the location. So this is the most vital part of the appointment. It's the point where if we get it wrong, we're essentially wasting a lot of people's time. So the patient would potentially need to come back for additional face-to-face. The photographer could then have seen somebody else. The clinician who reviews the images may need to see the patient face-to-face again anyway. And then also the GP yourselves, because we would be sending the patient back to, we may send the patient back to the GP for another referral. So that's why it's so important that all sections on the pro forma or the referral form that you complete are filled out with as much descriptive information as possible. If you're able to include photographs of areas that are especially difficult for the patients to see themselves, such as the back or the scalp, that does also help us try to pinpoint the exact location. We do mid photos as well if there's ever any uncertainty. And if the patient has an area not clearly stated on the referral, we would send them back to the GP to get that checked. Once we are confident that we have the location, we will then draw an arrow and confirm with the patient that area again, either using a mirror, if they can point it out, back of the camera, or if there's somebody with them who's aware of where they're being referred for, they can also confirm the location as well. And then we will then start taking photos. So if we go to the next slide, you can see the type of photos that we take. So this is just a kind of a standard set. Ideally, it would all be the same orientation with the position of the arrow being in the same angle, but yeah, we'll take an establishing photo. We take photos with two cameras. So both of them are DSLRs to get as high a resolution and quality as possible. With the first camera, we use a macro lens and we get an anatomical photo to start with, so that there's no uncertainty as to where on the body we're photographing, with additional photos like close-ups, potentially with side views as well. And then we move on to the dermoscope with polarized light built into the lens, and we touch that glass-fronted lens onto the skin, and the photo that you can see on the far right is an example of that. We use polarized light. We don't do it without the polarized light, and we could do it with and without pressure as well, so that it's clear to the dermatologist all the information, and sometimes blanching can help, and yeah, as I'm sure you're aware. And then if we move on to the next slide, please. It's an example of patient photos compared to the photos that we take. So as you can see here on the left is a photograph that we've been provided by the patient compared to the photos that we've taken the lateral views, or more oblique. It can help see if it's raised or not. And then again, next slide again, please. Another example of our photos compared to the patient photos as well. So when we upload the patient images, we upload them to the medical records where the clinician will review them. The dermatologist reviews the images alongside the referral and the questionnaire, and then they'll write a letter to the patient explaining what they want to do or what they think, so that where they can diagnose a discharge or diagnose and have a treatment plan. But the patient will find out via a letter, usually on their My Chart or in the post. But the main idea is that we just don't want to waste anybody's time, so it's really important that the referrals are really clear and accurate to ensure effective and efficient photographs of the patients. Some of the common issues that we come across with referrals are, as you probably tell because I've been bringing it up quite a bit, is the suitability of patients and the exclusion criteria being met or not. So unsuitable patients incorrectly booked via direct access. This is usually because they fit the exclusion criteria. And so that's why it's so important to actually complete that first part of the form, like ticking the boxes. And then please familiarise yourself with the exclusion criteria. I know there's a fair few bits on there, but it's really useful to try and sort of have it at the forefront of your mind. But it does happen quite a lot, and it takes up quite a lot of admin time for all to get the patients rebooked. So not just the photographers, but also the booking teams and the clinicians. And then also patient expectations. So we often have patients attend clinic with different expectations with regards to how many lesions we're due to photograph. But we are a single lesion service. However, we do photograph up to 2, but no more. So in order to help us manage patients' expectations, additional areas not mentioned on the referral will not be photographed, and we'll send patients back to yourselves if they want to get more checked. And just generally clear referrals. So please write all areas you want looked at on the referral. Do not only rely on the patients to point them out in the appointment, because we have many occasions where patients come to us and they say, oh, seeing as I'm here, can you photograph this? But for everyone's safety, it's just the safest thing to send them back to you to get them photographed, to get them checked, because it's not always, if it's not on the referral, we can only assume that it's not been looked at by a clinician beforehand. If you refer a patient directly to dermatology, unless the referral suggests they fit the exclusion criteria, there will likely be triage to teledermatology. And we do often get patients coming to us saying, oh, the doctor told me to show you this one, but they didn't mention it on the referral. And our hands are kind of tied with that when that happens, because we just can't photograph it and we send them back. And also the location not being clear on referrals. Sometimes it can be a bit ambiguous. So it's really important to be accurate with the descriptions, and so that we can photograph the correct area. Sometimes it's just written leg, or left or right is written incorrectly. So then we have to take overview photographs of other areas so that the dermatologist can see exactly where they're looking and can confirm that it's the right area. So always write the area using the patient's left or right. And if we can go to the next slide, please. So we do sometimes get challenging areas to photograph. Example to photograph with the dermoscope, particularly. For example, heavy bleeding or oozing lesions, because the fluid, such as blood or pus, can obscure the view of the structures below the surface that we can't see through the dermoscope with. But there's also the discomfort for the patient and infection control considerations to be had with that. Hair-bearing areas, as you can see with this photograph, and the hair obscures the view, and is best seen face-to-face to determine the extent of the lesion as well, to be effectively diagnosed. Another area is nails, due to be formally added to the exclusion criteria, which isn't at present. So in order to get an effective diagnosis, it is important for dermatologists to look at all the nails, as they are looking for streaks and ridges, which can be unclear in photographs and best identified face-to-face. That's all from me.
Thanks, Ella. I'm just going to hand over now to Dr. Koo, who will talk to us a little bit about the review process.
Hello. So thank you. So next slide, please. So during the review process, we'll look through all the photographs that have been taken by Ella's team, and we will generate a report based combining information from the referral, from the questionnaire that's been filled in by the patient, and the photograph or assessment of the photographs. The patient will receive a letter which is much like what you see here on the slide. It explained there is a part about the assessment. We describe what we are seeing in the photographs and our diagnosis. We summarize the background that's been provided on the questionnaire. We do use, there is a degree of interpretation here, which is why we have not just copied the questionnaire unblock from what the patient has written, because often there are irregularities within there. This is the what we believe to be the correct, what we believe to be correct. And then finally, there is a part about explanation. We'll explain what's going on, what we have found to the patient, and we will summarize it for we will summarize it much like we do for a regular clinic letter. There is a question, there is some caveats at the bottom, things about the lesions that are assessed are only what's been written on referral and what has been photographed. Anything which has not been had the demonstrable image taken is assumed to be not assessed. And on top of that, we explicitly do not offer a full skin check as part of this assessment, as it is one single lesion service. Yes, next slide. So yeah, I think Katie, this might be yours again.
Yeah, just as part of your outcomes, obviously these are the types of outcomes that we would expect. I think I've been through it already, but just to sort of give a bigger slide of what outcomes we would expect following a telederm assessment.
All right, yeah, go to the next slide now. And yeah, I think this is question time.
Yeah, so any questions from anyone at all? If you could pop your hand up, but it's quite hard to see with this many people on the call, and then we will know. You can also pop them in the chat if you want to. Give it a couple of minutes if anyone has anything to say. If not, then we'll move on to the training session by Dr. CUH. Hi, Joanna, receptionist. Yes, your Newport surgery. So we did limit it to our local Cambridge GP. So I'm not sure if Newport is in that, but if it's not, we need to expand it a little bit further. We were unfortunately getting patients all the way from Brighton, as it looked like we were the next available 2-week wait appointment. So we did have to restrict the yeah, so we will be expanding it slightly. Just the patients have to understand that obviously this is a local service, and it's not just a virtual appointment. They will still have to come on site. But absolutely, the receptionists can definitely book the appointments. You just need to understand that there will be multiple clinic appointments, because each of the different sites that we operate at will be a separate section on ERS, if that makes sense. Yeah, that's fine. We are looking at opening up a little bit further, so we will make sure that Newport is within that catchment. Just that we didn't want patients all the way from Brighton coming for an appointment. We have made the names clearer on ERS as well, so that should be quite clear to everybody of which service you're looking, which one you're picking as well on ERS, as we had that feedback from some of the GPs that they found it a bit confusing with so many different categories. Okay, well, we'll keep the chat open, and obviously following Andre's training session now, if there are any further questions, then we will obviously will answer them at the end. But I'll hand over to Andre to do his dermoscopy training session.
All right, thank you. So this is just this is a selection of cases. These are randomly selected from cases that were seen by my